I missed your face too. I just missed you guys.
Good evening, everyone. I'd like to call to order. Is that Lori? I'd like to call to order the January 26, 2022 Community Mental Health Board Full Board meeting. Please rise for the pledge. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thanks, Megan. Reading of the mission statement. Lori, please.
Macomb County Community Mental Health, guided by the values, strengths, and informed choices of the people we serve, provides quality services which promote recovery, community participation, self-sufficiency, and independence.
Thank you. Next is adoption of the agenda. I'll take a motion to adopt.
So moved.
Support.
Motion from Megan, support from Ryan. Questions, comments on the agenda? Seeing and hearing none, all in favor signify by saying aye.
Aye.
Aye. All opposed? The agenda is adopted. Next is item 4, hearing of the public. Anybody wishing to speak? You have 5 minutes on any item on the agenda. Anybody from the public? Nobody's jumping, so we will close the first hearing of the public. There's another one near the end of the meeting to discuss any item. Item 5, approval of the minutes of the CMH Full Board meeting on December 21st, 2021. Take a motion to approve those minutes.
Motion to approve. Support.
Motion from Lori, support from Selena. Comments, questions, edits on the minutes? Hearing and seeing none, all in favor signify by saying aye.
Aye.
Aye. All opposed? Minutes are adopted. Item 6 are the minutes from the program and budget meeting. We did not have a program and budget meeting, so we will move on to item 7. Request to approve. Item A is request to approve MDHHS CMH PIHP Amendment 4. Take a motion to approve.
So moved. Support.
Motion from Megan, support from Selena. Dave?
If you recall, our current PIHP contract was an extension of last year's. So it was a simple 2-pager. We continue to meet as the contract negotiation teams, and of course they're working on tweaking it as they go forward. When this came out, it appeared everything was appropriate. I am recommending that we approve it and sign it, send it over. But I do want to let you know that subsequent to probably like a week ago before this came out, the negotiating team did identify that what's in this amendment does not match what was in from the contract negotiation teams. So you should expect an amendment to the amendment. Par for the course, I know. That was my take on it as well. It does touch a number of areas in our contract. So when the amendment to this one comes out, I'll provide everybody a clearer update, and we'll make sure that we have internally addressed all of the changes that are proposed in the contract. So it's protocol and paperwork right now. Happy to answer any questions.
Seeing no questions. All right, we have a motion and support. All in favor signify by saying aye.
Aye.
Aye. All opposed? Motion passes. Next is request to approve MDHHS SUGS 2022 Grant Amendment 1. Take a motion to approve.
Motion to approve.
Support.
Motion from Lori, support from Ryan. Dave?
With Helen's help, I have some information. It is supplemental block grant funds of $1,745,001. It's a 2-year COVID supplemental block grant with the possibility of a 1-year extension for any carryover funds. The funds will be used to assist individuals impacted by COVID and the opioid epidemic. Services include prevention services, expanded opioid health home services for individuals not covered by Medicaid. We're planning to develop and operate an engagement center. The engagement center is a place for Macomb County residents to go if they are experiencing a substance use crisis, are in need of services, and they're not sure what steps to take next. The engagement center would employ staff who can provide support, screening, linking and coordinating to treatment services, stabilization, things like that. It'd be a 24/7. It would be open to everybody. They could go in. It's kind of that living room model where it'd be a very open, comfortable furniture, not clinical, I guess is the best way to describe it. But we would have the information and the referrals. So again, instead of, I know from personal experience lately, trying to connect people with services, you call, you get a friendly person on the phone, and they say, come in next Wednesday. When you're dealing with somebody with a substance use issue, that's not always the best approach. So we are looking at working with a consultant in this area who's set up similar programs successfully, and we'll provide more details. But some of these funds would go towards getting that engagement center up and running as well. And then it would also provide post-overdose response services, provide follow-up to the Macomb County people who had received police or EMT assistance for an opioid overdose to help support individuals to receive services. So that's how we're looking to spend that $1.7 million.
Questions? Mark?
Yeah. I have a question for you, Dave. On that response team, who are you going to be partnering with? Is that going to be local law enforcement departments, the sheriff, MedStar? How
That's
is that
an
gonna-
excellent question, and I'll ask Helen and get back to you. I asked Helen for an update, and that was not included in the update, but I'm happy to follow up and get that to you.
Because there are some already in place, that are doing that work. In collaboration with Macomb County Sheriff, Chesterfield Police, MedStar, and going out within 72 hours of an overdose and doing a follow-up.
Some of these might be extension of existing services and stuff, but I will get that detail for you.
Okay,
And
thank you.
to the board.
Thanks, Mark. Any other questions or comments for Dave? Hearing and seeing none, all in favor signify by saying aye.
Aye.
Aye. All opposed? Motion passes. Next is item 7C, request to approve MCCMH Board 2022 meeting dates.
So moved.
Motion from Megan, support from Selena. Questions, comments on the meeting dates? I'll just note that the times are staying the same. Program and budget and full board will be at 6 p.m. and recipient rights will continue to be at 8 a.m. and not 7:30 a.m. So that's nice. All right, seeing and hearing no other questions or comments. All in favor signify by saying aye.
Aye.
Aye. All opposed? Meeting dates are approved. Last is item 7D, request to finalize the contract to Health Management Associates, Inc. for the purpose of executing a comprehensive community needs assessment. Take a motion to approve.
So moved, Fantuzzi.
Support.
Motion from Ryan, support from Megan. Go ahead, Dave.
If you recall, we brought the request to release the RFP to the board. It's a contractual requirement under the CMHSP contract to complete an annual needs assessment. We've done this historically, and it's worked a little bit, and then when we did the initial Ccbhc expansion grant proposal as well, we were able to piece together a fairly decent needs assessment. We did utilize some of the stuff that was done by some of the other county departments, but I really think that with our mobile health unit, with the pandemic, with the trends everything that I read says that, opioid use is trending up, substance use in general, anxiety, depression, everything, everybody's more stressed than ever before. But to really assist us in our program development, our strategic planning, that we do a thorough, in-depth community needs assessment. So we did, the RFP, Health Management Associates was the selected, the best scored respondent. So now we would like to finalize that contract. We have had one, I was in one kickoff meeting after that. We'll be gathering data to assist them, and we've shared some of the other information about Macomb County that we had easy access to. But then they'll be doing, reaching out to stakeholders, various groups, and I think it'll be really helpful to us internally, to the board, and to the community at large. So.
Thanks, Dave. Any questions or comments? All right. Hearing and seeing none. All in favor signify by saying aye.
Aye.
Aye. All opposed? Motion passes. Next is item 8, receive and file. We have no items there. Item 9, resolutions. Same, no items there either. Number 10, voucher listings. Take a motion to pay the bills.
So moved. Support.
I think I heard Antoinette and Selena. Yes. All right. Questions, comments on the bills? Hearing and seeing none. All in favor signify by saying aye.
Aye.
Aye. All opposed? Bills are paid. Next is item 11, the CEO update.
Well, good evening, everybody. We have had some changes at the leadership level. You approved the resolutions for Bill Ladragna, who is our Chief Information Officer. I'm happy to announce that Thomas Cole, who's been with us, has been officially promoted to our new Chief Information Officer position. We met with him, Adam and Tracy and I, earlier today. Very good kickoff meeting. We'll be looking at possibly bringing in an outside source for him. So you might see that contract coming to the board as well. Thomas is very well prepared and had been working with Bill ahead of his retirement. I simply just don't know what I don't know. And I don't want to make sure we're not missing some important piece on that. And he was very open to that. He's already, he's been participating in our meetings, and it's all the feedback has been very positive. So I would like to officially congratulate Thomas on his promotion. A couple of other updates. We had our kickoff meeting. We are working with the state of Michigan on our Ccbhc, the demonstration grant. So we are one of 14 sites in Michigan working with the state, started in October. We will be working with designated collaborating organizations, or DCOs. It's a little tricky. I'm describing it as we have a Medicaid mental health provider network, residential providers, everybody else. We have a substance use provider network. Now we're going to have a network of DCOs underneath that Ccbhc kind of coverage. Some of the wrinkles with that are that all of their services that they perform have to go to the state as if they were our services. So we will be doing all of the billing for those under that contract. So the providers will be submitting service activity logs. We'll be doing the third-party billings, the collections, including the ability to pay collections, and sending all that data to the state. So we're getting things set up. We had a kickoff meeting. The designated collaborating organizations to start with are the primary caseholder agencies that are currently under contract with us. So the providers that are doing intakes and coordinate, the the primary case management services. They'll be our DCOs. We will also, probably down the road, add our substance use providers because substance use is a part of the CCBHC services as well. But that's how we started. Really good dialogue. Very happy, and I'd like to congratulate our team, Agnes and Ann, Sabrina, and then Ken from our finance team, and Amy Norman as well. Did really good in explaining it, going through there, answering questions. So we're off to a really good start, and we'll be able to provide updates going forward about the type of activity we're seeing underneath that. But the way it's set up now, if you recall, they no longer have to be a resident of Macomb County. We can now see people in the mild to moderate categories, so you don't have to have a severe mental illness, and we can see people with third-party insurances and things like that. So the front door's wider than ever, but we have a really good network in place. A lot of them have been working with CCBHCs previously, like Easter Seals. So we're off to a good start. Along with that, if you recall, we were operating the expansion grant for CCBHC, which was directly with the federal government, the SAMHSA, the Substance Abuse Mental Health Services Administration. That expires in April. We did have some unused funds, and it be possible for us to extend that to try to run out those funds. After a thorough review, met with the program staff on the CCBHC side, talked to finance, with Adam and things. Running those parallel, the expansion and the demonstration, creates problems. It's not an easy differentiation about who goes into what program or funding bucket. The reporting requirements are different for the expansion than the demonstration. They're actually more under the expansion. So now on the clinician side, if I'm seeing somebody who's under the expansion, I have to collect additional data, and then that gets reported directly to the federal government's site, as opposed to folks under the demonstration who don't need all of that information, and the reporting goes to the state's database. I very much want us to focus our efforts on the demonstration, and we'll be able to show more activity under the demonstration, pretty much transition the folks who had been under the expansion grant. Kind of that should be a fairly smooth transition under the demonstration, so we can start showing that activity. So I did make the decision to not pursue the extension of the expansion grant, and to focus our efforts on the demonstration project. Happy to answer any questions about that. Yes.
And you kind of just answered it, because that was going to be my question, is if we were going to go after both tracks or if we were going to consolidate, because that will be a nightmare for our CFO.
Yeah.
To have both of those as new projects.
It's a nightmare at all levels when I went through it, and we had thorough discussions. And because of the funding situation that we're in now, which is very positive, it seems, just bizarre right off the cuff to say no to those funds. Our goal was 3,000 people by April 1st. We're incredibly close. We'll be in the 90 or might even exceed the 3,000 people. So then the only reason to extend it would be to run out the funds. And, we've met our goal. We did well under that. And like I said, I think if we focus, we need to focus on the demonstration. We've got a lot of irons in the fire with the same-day access, with our NCQA consultants who are working with us, with the pandemic and the staffing shortage. So this one was I think, very much the appropriate move. On the finance side, as a nice segue, we have asked the state for a 30-day extension on our reporting. We did have a number of our finance staff off for medical, and there was a delay in our reporting. So you'll have a full financial reporting next month. The Cliff Note version is that the federal emergency was extended at least through September, possibly through the end of the calendar year. So what that means, again, is nobody's being disenrolled from Medicaid. So our Medicaid eligibles continue to grow. Our Medicaid capitation is tied to Medicaid eligibles, so revenue will remain high, and very positive. So there's no, we're not concerned right now about any, negative issues on the finance side, and you'll have all that detail next month. The request the FSR was due, I think February 1st. They've asked to push that back to March. The state was looking at that. I don't know if they've responded yet or not, but they've been lenient given the conditions everybody's trying to work under. Also on the finance side, I've mentioned before, and you heard public comment, we would like to do some rate adjustments. I'm not clear, I guess historically, but it's not codified anywhere, rate adjustments came to the board. We're more than happy to do that, but there are timing issues. We had proposed a 5% annualized rate increase across the board. Starting that in January would be a 6.67% increase across the board. Starting in February, it's 7.5%. Would like to go back to January. Would like to do a hospital rate per diem for all of our contracted hospitals. Again, we've reviewed that. We are lower than the state average for sure, and lower than our neighboring PIHPs. This will get us closer to being at par. And again, I've talked to Adam and stuff too. In conjunction with the rate increase, we need to make sure we're managing the inpatient utilization appropriately, looking at average length of stay, looking to make sure those transitions out of the hospitals are as smooth as possible. And then the board requested we do a rate comparison. That's in process, but it's taking a little bit of time. And so what I would like to propose is the 6.67% across the board, except for hospitals, effective January 1st. Then we would bring the rate comparison detail to the board next month, along with the specifics for the residential is not a service, it's personal care and community living supports in a specialized setting. But those is where we're seeing a larger variance than the 5% annualized. So I'd like to do this kind of in steps, do the 6.67 effective January, then do the hospital per diem, and then look at the residential per diem specifically, and come back to the board with more detail on that. That would be over and above the 6.67. I'm open to that. If you'd like to go through the board process, it would be 8% something effective in March if we put this through the February board process. But we do have the funds. It's under contracted services. There's no budget amendment. It does also take us time to calculate the new rates, and then get those new rates into our system, communicate those to the providers, and have them start billing. So I'm concerned about the timing factor in here. But again, it's the board's discretion, and I'm happy to, whatever you would like.
Ryan?
Mr. Chair, Dave, I just have a couple questions. So are you proposing immediately we raise to a level that gives all of our providers some kind of relief now, and then once we get more data, that's under what we probably should be, but then we find out where we should be, and then we make up that difference later once we have more data?
Yeah, the largest differences are on the
What is that?
on the group home side,
Okay.
on the residential services.
Okay.
Those specifically, there's more than a 6.67% difference from our preliminary information. So we're gathering details on that, and we'll be able to bring a comprehensive report back to the board in February's program and budget.
Okay. And is it a 6% and then a 7 and an 8, or is it just 6 for now?
It's a 6.67, which is 5% annualized, but starting in January for 9 months.
Okay.
If
Can
we would
afford
have
it more-
started on October 1st, it equates to about...
Oh, I see. Because it's taking effect in January, annualized, it would be a 5%. Got it. Okay. Now I
And
understand.
it equates to about $10 million across the board at the 5% annualized.
Assuming we're never going to decrease it, I mean, can we afford this for the long term?
Hopefully, yeah.
Okay.
We will do I mean, I can't, if you get another, $100 million Medicaid cut. But yeah, finance has been working with us. That's, in our wheelhouse for the foreseeable future, 3 to 5 years.
So, okay, if you need immediate action from the board, is this something you would want us to vote on tonight to move to program and budget?
My
or-
question is whether or not it's an action item. I don't know if rate changes are actually require a board action or not. I cannot find that written anywhere.
Well, I guess there's no harm for, having some belt-in suspenders, I guess, right? But just to authorize anyway. But anyway, that's just an idea.
Thank you.
Thanks,
Thank you,
Ryan.
Mr. Chair.
Megan and then Nick.
I was just going to ask, the budget stuff, it confuses me with like the county stuff and then the CMH stuff. So if, let's say we did what Ryan said, like let's say we did it tonight and we said we want to do it right now. Would that still have to go to like the Board of Commissioners for you guys to vote on it because it's a budget thing, or not at all? It's just totally up to us.
There's no budget amendment involved.
no budget
We have the funds available under contracted services.
So we can just do it. Got it. Thank you.
That's my understanding, yes.
Okay.
Thanks, Megan. Nick?
Yeah, when the budget was all screwed up, I don't know how else to say it, and we were making massive cuts, we did do that through board action. I had asked some time ago, and I specifically remember a 5% provider rate cut as part of the budget balancing pieces, but I thought we had done that restoration. And I think we did that by board action. I'm trying to get to you whether you want us to vote on it or not. But I thought we had done that. Now the next 5% is what, intended to try to bring us to parity, isn't it? Or move us toward parity with other areas.
And given the revenue situation and everything, our projections are that we would lapse Medicaid dollars again.
Right.
This gets the dollars out to the providers who we do meet with the Provider Alliance. That the staffing crisis is really taking its toll. This does not cure that in any way, shape, or form, but it does, give them some relief and sense of comfort. And as opposed to, we have provider stability payments that are still being processed and made available to providers, but it's they're not everybody's taking advantage of that. This kind of elevates everybody, helps out the whole system, helps our year end.
But the rates aren't earmarked. And we're not co-employers, so we don't know where they necessarily use the money except for the $2.
Yes, this is
piece.
different than the direct care wage pass-through.
Right,
Yes.
although it may go to direct care worker salaries, because that's one of the areas they're having
Yeah,
the
they
most
need to
difficulty
recruit and
in
retain
attracting
the staff
workers.
that they have.
But do we know from your discussions with the Providers Alliance, do we know where the biggest shortfalls are? I know direct care is a problem, but I don't know if middle management, rent, well, they don't do rent, but other operating costs.
We
are
will
the
we will
areas
be
of
able to submit a large spreadsheet that shows all of our contracted providers, their fee schedules currently, and then at the new rate. And we'll also be able to have a rate comparison in there in some of the like categories. So it might not be a specific code, but we'll categorize them as assessments or individual therapy and things like that. Yeah, we will get that to the board. So you'll be able to see how we are. But by and large, we're lower than our neighbors. And this helps kind of level that playing field. And then, like I said, the residential services, we do have that's where the greatest discrepancy is.
Well, as you're looking at whether or not you need board action or you can just do it, I'd just tell you from my recollection, we did the 5% rate cut by board action in response to the budget problem. I think there's some wiggle room in what you can do without it, but it's probably best to just, as long as, I can't speak for the other board members, but from my perspective, as long as you tell us what you're doing, and we have a chance to object if we do, then I'm less concerned about formal action, but you may need formal action. And,
I'm happy to bring it to February as a 7.5%. Probably it'll be 8% or something. We can start it in March. Going too far retro once the claims are already in is a problem. So yeah, we can do that along with the hospital, and then we'll have more detail on the rate comparison and what we're recommending specific to the residential per diem.
That makes sense to me because, as I said, I think rate making has come before the board traditionally.
Okay. And then, like I said, there is a timing issues internally. We do have to then calculate those new rates, get those new rates into our focus system, communicate those new rates to the providers so they can start billing. But we'll start priming the pump now. So thank you. Now you know what to expect at one thing in February's program and budget.
Megan, real quick.
I thought I had it, and then Nick asked that question. So layman's terms wise, does that mean that not all of that money, we don't say that money goes exactly to wages and it goes to wages? They can kind of do with it what they want, though?
Yes.
That makes me nervous a little bit. Can you calm my heart about that? Because that just sounds like...
the direct care wage increases went through, and those are specifically earmarked to the direct care workers. From talking to the providers, staffing is their biggest issue right now. So they're focusing on recruiting and retaining those staff. And they said anything we give them would go towards their personnel cost. I believe that. We might have some folks out there who choose to do other things with it. But again, what we pay them now isn't specifically earmarked to go, this much has to go towards... Yeah, we don't do that. But this does help our provider network. This helps our, like I said, our on the finance side. We are doing well. And this, like I said, annualized, we're projecting at $10 million at that 5% annualized. The residential rates, we'll get you that detail in those annualized projections. The hospital per diems, for every $25 increase was projected to be $1 million annualized, and we're proposing 50. So then I'll bring that forward to February as well, along with the comparisons to the other regions and stuff, so you can see that that puts us closer to being at par with them. Yeah, so it's nothing extravagant. And again, these are all supported with our financials, which you'll have a full report next month too. So they go hand in hand.
Dave, if I can jump in real quick. This right here is just another perfect example of what Dave and I have been dealing with for a while now with the Executive's Office and the Board of Commissioners is, where's everybody's lane? What can we approve? What do we have to approve? Yes, as Nick said, we have approved it in the past, but did we need to? You know, and that's, you know, or could the CEO just do it? And when we add items to the agenda without a formal motion and we just start voting on things, we cause heartburn downstairs. So that's why Dave and I sort of discussed this before the meeting, and I said, go for it, ask for forgiveness, you know, and see what happens. But past practice has been for these items as it's come to the board for approval. So that's where we are trying to iron out those details as to.
Right, and in talking to finance earlier today too, historically the budget, going back, the budgets were done differently. With Richard in place now, what the county's instructions to us are is we budget at 100% of the revenue. So instead of kind of projecting like what we think actual cost would be, we budget everything. So under contracted services, there's a lot of money in there. And because of that, you know, if we added, you know, a $10 million annualized on the providers or $2 million on the hospital side, that's in there. If we had projected it, if we had budgeted it differently, then that would have caused a budget amendment, which then would have had to go through this board and gone through the Board of Commissioners. But right now we have that kind of built-in buffer. So, but I'm happy to bring it as a formal board action next month with the supporting detail. So this was a good heads up.
Donna?
Yeah, you also mentioned that you were looking at raising for the hospitals too. Are you going to bring that to us in February also?
Yeah,
Yeah.
we'll be proposing a $50 per diem, and it's projected $2 million annualized.
I don't know what they get paid now, so maybe you can kind of give us a spreadsheet
If
for
I
that
recall,
too.
it's about $650 a day right now, and we'd be at $7. No? No. Lower than that. We'd be closer to 7,
Maybe
but
you
not
can
quite
show us
there.
what they get paid now.
You'll have-
and
yeah, I'll
like
have
maybe
that
what the
detail.
surrounding communities, you
Yes.
know, kind of a spreadsheet for them too, because I don't think any of us have any
You
idea.
will have more detail than you probably wished for.
Well, don't give us too much.
For February.
I mean, you know, a minimalistic view will
Yeah.
be nice. Okay, thank you.
I'll try to hit some of the highlights in there for you. But
Okay.
we are working with an extensive spreadsheet by provider. We do not yet have a standardized fee schedule.
Okay,
So there are variations in there. So because of that, the amount of rates that are impacted it's rather long.
but
So
we're
we-
below the surrounding communities
By
with the
and large,
hospitals
yes.
also, is what you said?
Yes.
So, yeah, okay. I mean, that's all basically we need to know, I think.
But yeah, we will provide you detail and be happy to go through that with you.
Okay, thank you.
Thanks, Donna. Ryan?
I'm fully in favor of getting up to market and even above the market to help with recruitment and also help the providers in any way. And so once we find that number, but in order to just, like you said, it's not going to solve the problem, but if it could at least stop the bleeding for a while, let's take immediate action. I'd love to do that. I guess this is a procedural question. I know that we typically approve things at program and budget, and then we have final approval at the full board, and we do that. I think the history to do that is to have some, where, I don't know why we do that, but I actually don't know why we do that. I just know we do that.
Neither do
I'm sure
I.
there was a reason for it in the past why we did that. I'm wondering if we're going to approve this with a final, we're done, in February, does it make sense, I know we have program and budget in February also, but to make a motion now, subject to, obviously approval at the full board, that way it's out there, there's a formal resolution a formal motion rather. I mean, I don't know if that's the right call or not, but that way it's still following our internal procedures. If you think it's necessary, Nick is the parliamentarian, so he.
Yeah, if I can,
ahead,
I
Dick.
mean, program and budget is a committee of this board, so it can't take final action. It can only recommend action to the full board. That seems a little strange to most of us because program and budget is a committee, but it's a committee of the whole, so you don't usually see any major change between the actions of us acting as a committee versus the action of us acting as the board, because the same people making, unless you're going to change your mind suddenly. But that's the procedural reason we do it that way. I think it would be uncomfortable to try to make a motion in anticipation of a motion, which is essentially what you're talking about now. I have suggested, and maybe Phil, you and I can have a conversation online about this later on, is that we may want to take a look at our bylaws because they may need some updating, and if not updating, some clarification, because if you're having trouble figuring out whose lane it's in, that's probably where the resolution should be. So I haven't looked at the bylaws in a long time. I'll take a look at them again, and we can have some discussion at some point about whether or not they need to be, I suspect it's more clarified than updated or just modernized or whatever.
Thank you, Nick. I think that's clear. What about just something very rudimentary like motion to add to the agenda? Is it completely unnecessary? I guess I have a little bit of agita over getting our hands slapped at one time over that one particular, we don't even need to go there. I just want to avoid any of those kinds of problems.
We can go through the normal process.
Okay.
What we can do as well is we can start the internal stuff now and through February so that pending board action, we're ready to push the button, pull the trigger on those changes.
Thank you.
Thank you. Nothing else to report?
As chair, you can.
Anybody else with questions for Dave on any of the
Any questions of Dave?
topics? No? All right. We will move on to, so you thought seeing things twice was bad. This one you're going to see 3 times. Discussion of the special assessment. I put this on in this spot because it was supposed to be tabled to program and budget, but we did not have program and budget. And I wanted to discuss it a little bit before throwing it on full board with numbers and things like that. Dave has been great in giving us information from the attorney and some dollar amounts and all that good stuff. So according to Aaron Thomas, it's perfectly fine, who is part of Corporation Counsel here. He signed off on it. Dave gave us the number, which I can't remember off the top of my head, but I think it was somewhere around 35,000-ish. So I just kind of wanted to have a quick discussion here, and then at program and budget, we would be able to put, yay or nay and a dollar amount, but I didn't want to do all of that at full board and run with it. So if there's any suggestions, comments from board members, I'd be happy to hear it. You can speak now. You can send it to Dave and I in email form, but it's just more for the purpose of creating basically an agenda item and a motion for program and budget that's clean, and we're not just tossing around 5,000, 100,000. So if anybody has suggestions, feel free to speak now or email us.
Mr. Chair?
Ryan, go ahead.
I did express some concern a couple months ago over this. Now with corporate counsel weighing in, all my concerns have been answered. So I'm ready to vote in favor of this.
Thanks, Ryan. I had very similar concerns, so I was calmed by Aaron Thomas's response to us. Any other board members? Any? $34,517.
That's the total of the PIHP fees and the CMHSP dues for 2022.
Nick? Donna's pointing at Nick. Nick's looking at me.
Yeah, if my mind's in the right place on this, this is the special assessment that the state association has asked for as an educational to put into effect an educational program just concerning the structure. And if you were lobbying, that's where we got into a headache, whether we were lobbying or educating, and Aaron has figured out how the proper way to do that. A number of boards, I don't know the number, have already moved forward on it. I think it's a good idea, assuming we can do it legally, and Aaron says we can do it legally. I'm going to argue with him. The intent now is to place the specifics, because we don't want to get into the mess Ryan talked about earlier and, pick pieces out of the air. We want to have a well-drafted resolution and go through the process. Is that, am I right on all of that?
Spot on.
Okay.
Yep. Thanks, Nick.
I will draft a board action that details the amount and what its intended use is.
Anyone else? All right, we will move on from that, and we'll bring up Stacy. Compliance, quality, due process, quality assessment, and process improvement plan update.
Before Stacy starts, I owe you an apology. I mentioned some retirements of staff and some changes in our leadership, and I congratulated Thomas Cole as our new CIO. Cindy Conal's retirement as Chief Quality Officer. Stacy has stepped up into that role. So Stacy is now our Chief Quality Compliance Privacy Officer, who also does the hearings. Apologies for that, Stacy, but welcome to the podium.
That's okay. Other duties as assigned is kind of how I take that. Thank you for letting me speak again. When I was here in November, I talked a little bit about the Quality Assessment Process Improvement Plan. This is a plan that is written annually that has to be approved by the board. That has to be approved by the board. It is not ready for your approval yet. I was actually out on medical, as is the other administrator in quality. It's been quite a last 2 months, but I'm first going to give you some departmental updates. In quality, Cindy had retired. I've taken over that position. Lori Baumgard has retired as well. And we have 2 other staff who left the department prior to me taking it over. So we've got all kinds of positions, plus they had positions open before. I'm doing a reassessment of the department. I'm working with Dave and Adam and Tracy to look at the department and the roles within that department. And we did do job interviews, and we offered a position to 1 person. So I'm kind of excited. Hopefully we'll have another case manager to add to the mix. At this point in time, I did ask the quality staff who do audits to suspend those audits. They were going to start the hospital audits in February and March. I saw no reason for any other stress to be placed on the hospital. Yes, I understand that they normally do them on an annualized basis, but I don't want hospital staff to have to be looking for documents and preparing for meetings and things like that. So at the end of March, we will assess. We'll reach out to the hospitals and ask, hey, is it a good time to come or not? I have no issue with them being not on an annualized basis. I want us to be able to do this on the provider's convenience, as long as we meet the standards. I did the same thing for the residential audits. I have put those, we're not going to start them. Though we had announced the schedule, the providers did have a sigh of relief when they heard that we were going to suspend those audits for right now. Everybody's going through a whole lot with staffing changes, and they're overburdened. So I'm actually taking a look at our assessment tools that we utilize. Ours are much more rigorous than other counties, and we'll be readdressing that actually with the provider network. A couple of the providers and I have had some discussions about our audit tools, and some of the standards that we have set. I want us to have very high quality standards, but I also don't want us to create an administrative and undue burden that providers can't meet. I don't want them to spend more time on a corrective action plan than providing services to folks. So stay tuned for that. With regard to quality, so we have a quality council. In the past, it was basically our administrators at the agency, the directors and chiefs, and I felt it really important to have some board involvement in this. And so I reached out to Megan and asked her if she would consider participating in our quality council as a board member for the agency, so she'd have a higher level of awareness about the quality activities. And because she's already participating in the compliance, and I thought we'd hold them all on the same day, again, wanting to maximize her time, but also I want the board to be more involved in the quality activities of the agency. Actually, quality now reports to Dave directly, so that he's always getting an earful about quality activities. So with regard to compliance, the new OIG template finally came out. It's as confusing as the old one. And thank you to Madison for Licky. She actually did a PowerPoint presentation with a voiceover. And we sent it out to all the providers. We said, hey, look, it's not as bad as it seems. Here's how you do it. We've gotten probably 30 questions about it, but that voiceover made a lot of difference to them, and we sent it out to the providers. Christina and I are working really hard to merge quality compliance and the provider network operations activities so that the providers feel more comfortable reaching out directly to us. We're also going to discontinue requiring providers that were only residential to submit the OIG reporting forms. It's ridiculous for them to go through and go, what are my quality management activities? Didn't make a lot of sense to me. I had the amazing opportunity to host students from Oakland University. They had reached out to Tracy Smith to ask, would someone be willing to host a group of students in their master's program for public health administration? And I hosted 6 students and met with them, and they basically said, what's a problem you're having at community mental health? Well, what's the first thing that we come to? Staffing. So they went down a rabbit hole with they wrote a project about assessing why are we having staffing issues, and they did a survey, and it was fantastic experience. They wrote up this study. They invited me to their presentation night with their reviewers, and they've asked us to come back and participate again. So it looks like I'll be hosting some additional students. What I hadn't thought about was the plethora of students that graduating with public health administration degrees that would be phenomenal to work in community mental health. 3 of them have already reached out to me about employment, and actually 2 of them will go, hey, I've got this project due. One of them, her project was, I need to know something, a public policy issue that is impacting community mental health right now. Could you tell me what it is so I can write a letter to my state rep? Well, I sent her the Shirky bill information. She sent me back the letter she wrote. She had included things that I hadn't seen in the Board Association packet. It was phenomenal. It was a great experience, and I'm looking forward to kind of tapping OU for some of those students in the future for positions. With regard to due process, we have no Medicaid fair hearings. I don't know, we must be doing everything right. Local appeals have increased. It just happens, Lori retires, local appeals increase. We're seeing a fair number of overturns, upholds, but it's not an issue. I do have to revise our training that's in the LMS system, as well as all the templates. Thankfully, Thomas is here and is able to pull. PCE has a standardized version that all the PIHPs and CMHs use, so we'll be utilizing that soon enough. With regard to this quality assessment process improvement, it's been presented to you in the past, and basically it's usually about 58 pages, and it's a big document. This was the very first year that the Department of Health and Human Services graded it. They scored it. So they actually went through the elements and said whether you passed them or not. They've never done that before. Basically, before you handed it to them, they said, thanks for playing. They scored ours this year, and we didn't do a rule wall. We hadn't met a lot of the elements. And again, they focused on what those key performance indicators were. We didn't have a lot of our process improvement plans related to the key performance indicators. As I had expressed before, key performance indicators is our report card to the state. Okay, it's not just comparing us to Oakland or Detroit, Wayne, or Northern Michigan. It's how are we meeting these standards that we're contractually required to meet. And some of them do have disallowances in them. So, you know, this is a thing, right? And you don't want to be on that very bottom tier. Just as a super brief overview, there's actually 6 indicators that we're graded on, that you have to meet a specific type of standard. Of those 6 indicators, there's 17 objectives within those various indicators. Last year, we only met 3 objectives out of the 17. So I'm talking across the board all year long. The rest of the time, it was red numbers, meaning we didn't meet the standard. If the standard was 95, we were at a different type of standard. This is something that it's really not very acceptable. You know, Dave and I have been talking about this an awful lot, and I've talked to Lori Baumgart. You know, process improvement plans would be put in place, but it just didn't fix the issue. I believe with the strategic planning method that we're engaging in now with the ROC formats, that we will have much better luck with these. One standard that they look at is our penetration rate. Ours is the lowest in the state. We serve the lowest number of people percentage-wise. You know, a lot of people would want to say, well, there was COVID. This is something that Macomb County has had going on with their key performance indicators since I've been in quality, and that's been a really long time. So it has nothing to do with COVID. When our process improvement plan, our formal plan that was written for a project that we were supposed to have accomplished last year, we're the only ones who didn't pass. The state said, you didn't pass. And it was about, that one was about hospital recidivism. Well, that's one, you know, we know that behavioral health needs increased because of COVID. We can't blame it on COVID, it had nothing to do with COVID because we've always been recidivists in that area. So those will be very large focuses, all of the things in the QAPIP. It actually is a very detailed document. I went through the report card that the state gave us, identified all the areas. We wrote some really nice stuff, but we didn't have actual goals and objectives for them. I think of this like case management of key performance indicators. Measurable goals and objectives. As we go through the NCQA, actually, ironically, today was the day they looked at our quality area, and they said, this isn't a quality assessment process improvement. You don't have measurable goals and objectives. You also don't identify the humans responsible for these things. So this will take some work. It's going to look a little different for you. When I bring it to you next month, though, hopefully you like it and it's good because I have to give it to the state by the end of the month. I don't have a lot of wiggle room there. It's going to be, you know, it's going to be a big endeavor, but we've got a really active team, and I think with our current strategic planning initiatives and leadership that we will, I know compliance is on board with whatever quality says needs to happen, so we've at least got that vote. But we do have to have a lot of things in place, and with NCQA, a lot of what they talked about today was the focus on clinical standards, that this is something we need to be looking at best practices and actually measuring. It's great to say we're going to do a best practice, but is it improving care? Ccbhc actually has some quality assessment process improvement activities as well, and they're doing an amazing job tracking theirs with data. A big thing that's going to be key with the quality assessment process improvement plan, though, is data. I'm so thankful that we hired Rachel. She actually can pull a report for me. I can ask her a question, I have a report. You know, people want to say the data is bad, but that's the data that we're giving the state, so that's what I have to work with. She's been a huge help, so we will start becoming a more data-driven and a better performing community mental health services program and prepaid inpatient health plan. Does anybody have any questions?
Thanks, Stacy.
Just some follow-up comments to the penetration rate. The state simply takes the number of Medicaid eligibles and divides it by the number of Medicaid people who we've reported a service on. I have been speaking to that since I started because Macomb is traditionally at the bottom of the 10 regions. So now with the customer service and that single public-facing phone number, those were steps in that direction, because you have to answer the phone to get people in, spread the word. Kathleen's in the audience too. The increased marketing and outreach, spreading the word. We are also working with the board approved our MTM consultants to do the same day access. They're actively working with us now too to help that front door and help people contact us easily and get those services easily. And then as Stacy mentioned as well, the NCQA consultants are actively working with us, and it's very much data driven. So with these things we have in place, hopefully we'll start moving these the key performance indicator needles in a much more positive way. But it's it's very comforting to know that we have things in place right now, but it's a long-standing problem. So thank you, Stacy.
Anyone have any questions for Stacy or Dave? No? All right. Does any board members have any other items to discuss? I just wanted to mention briefly, our next meetings, now that they are approved, are going to be February 9th for program and budget, and full board is going to be February 23rd. And on Thursday, February 3rd, next week, hopefully in committee for the Board of Commissioners will be a resolution opposing the Shirky bills. And hopefully Dave can come and help out. All right, seeing no other board member. Ryan, go ahead.
Just a request from Sandy. Could you email us an invitation for all the boards? Oh, yeah. Oh, okay. That's all. Thank you.
You have to open them, right?
Oh, yeah, that's right.
Report sent, just not opened. All right, with that, anyone else? All right, we will move on to hearing of the public.
Good evening, everybody. My name is Sean. I'm with CEO, just to give the monthly report. For our Anchorville location, they went bowling and had cooking classes where the person served made Rice Krispie treats, pancakes, and hot chocolate. At our Clinton Township location, they upgraded their internet throughout the building, and as well, they also expanded the art room to make more crafts and other accessible items to our person served. At our Madison Heights location, they continued to deliver Meals on Wheels. At Mount Clemens, they attended Henry Ford cooking and exercise classes. At Pontiac, they had a holiday and New Year party for the person served. At Washington, they hosted their annual dinner with Santa that raised over $600, and they also delivered over 160 Meals on Wheels. At all of our locations, holiday parties were held in late December and included a free home-cooked meal for each person served. They also received a stocking filled with supply snacks and their yearly reward. CEO is now requiring that all employees by the middle of March obtain a chauffeur license. And CEO is also developing some initiatives for 2022, a summer program camp at Metro Park the week of June 13th, and then that Friday will be our annual company picnic party. Our Mount Clemens location will not be our Creative Academy location, and it will have an updated venue outside for more picnic areas. And then lastly, our Clinton Township building will be building a nature center and nature trail this coming spring and summer. And then just lastly as well, any talk or proposals of wage increases or discussions much appreciated by the company and the staff included. Thank you.
Thanks, Sean. Anyone else for hearing of the public? Kathleen? No? All right, we will close hearing of the public, and I'll take a motion to adjourn. Motion from Nick, support from Lori. All in favor? Aye. All opposed? We are adjourned. Have a good night, everyone.